Welcome once again, Dr. Matt Masters from DrugFreeAustin.com.
Hello, I'm Dr. Matthew Masters from Austin Addiction Medicine Associates, and I'm going to talk to you today about outpatient detoxification from fentanyl. Right now, we are in the midst of a fentanyl crisis, and the number of deaths is rapidly escalating. At any rate, we have basically three different approaches to detoxifying patients from fentanyl and treating them with maintenance medications to replace the strong opioid, which is fentanyl. At any rate, the first form of treatment is methadone maintenance. And methadone maintenance involves going into a methadone clinic daily for the first several weeks, and usually you have to attend very early so that you can get to work on time. So typically they open at 5:30 or 6. They see patients until about 9. Then there's a break and they see patients again, and the clinic typically closes at 1 p.m. If you miss your dose or you miss those times, they will not give you a replacement dose. So the advantage of methadone is that methadone is a full agonist at the narcotic receptor in the brain. What does this mean? It means that methadone fully stimulates the narcotic receptor in the brain just the way fentanyl does, but it's not as strong as fentanyl. So fentanyl is 50 to 100 times stronger than heroin or morphine, and the dose of methadone that you can start at, the maximum starting dose, is 40 milligrams. And that's very low, so you are likely to be experiencing ongoing withdrawal due to fentanyl until they can get you up to a decent dose of methadone. For most methadone patients, that dose is between 80 and 120 milligrams per day. But with fentanyl, it can sometimes go as high as 200 or even higher than that. The other form of treatment for fentanyl detox is to be admitted to an inpatient facility where the attending physicians convert you to a short-acting narcotic and wait for the fentanyl to come out of your system. And this can take 7 to 10 days. This is usually done in an acute care facility. It is not typically done in a chemical dependency facility, which is intended for inpatient rehabilitation. One of the worst things about being transferred to inpatient rehabilitation for substance use disorder is that they don't really treat opioid dependence correctly. Only 1 in 3 facilities, inpatient rehab facilities in America, treat opioid dependence correctly with maintenance buprenorphine or maintenance methadone, but 2/3 do not treat it correctly. So it's an expensive way to go, particularly if you don't have insurance, and there's no guarantee that you will receive standard of care treatment. The last option is outpatient detox, which is what I offer. Outpatient detox is considerably cheaper, and it involves the temporary use of controlled substances to help you come off of fentanyl in the most comfortable manner possible, and then to introduce buprenorphine, also known as Suboxone. One of the dilemmas associated with fentanyl treatment is that often physicians give buprenorphine too early in the fentanyl withdrawal process, and what that causes is a very uncomfortable withdrawal state known as precipitated withdrawal. Once that happens, addicts don't want to go back to using Suboxone or buprenorphine because they've had a real bad experience with it. My approach involves having both the patient and a reliable caregiver, which is usually a sober individual who either lives with the patient or is closely related to the patient, who can look in on them 24/7 for about 7 to 10 days while they go through this process. The interesting thing about fentanyl is it differs markedly from heroin. So in the past, 95% of the heroin on the street was Mexican black tar heroin. And if you were doing Mexican black tar heroin and you stopped doing it or you ran out of supply, you would go into full-blown withdrawal within 8 to 12 hours. That's not the case with fentanyl. I've had patients who have stopped fentanyl and they haven't gone into withdrawal for 24, 48, 72, even 96 hours. And the reason for this is that fentanyl accumulates in the fatty tissues of the body and continues to be released into the circulation, such that if you overdose on fentanyl and we give you Narcan and bring you back, if we don't continue to monitor you and give you additional Narcan, the fentanyl in your system can come out of the fatty tissues and poison you once again, causing respiratory depression and overdose. So it's often necessary to dose patients more than once with Narcan to keep them alive following an overdose. And of course, overdose rates are much higher on fentanyl because it is so strong. If you are using fentanyl and you don't want to quit using fentanyl, I highly, highly recommend that you use fentanyl test strips. And in Austin, Texas, you can get this from Needle Exchange. They will give you some test strips, and when you cook up your dope, if you stick the test strip in there, it'll turn purple, and that will tell you that fentanyl is present. If fentanyl is present, you need to not shoot up alone. Most of the people who die of opioid overdose die alone because it's pretty much a shooting heroin or fentanyl is pretty much a solitary activity. People don't tend to shoot up unless they are running buddies or unless they are a couple. So if you are going to shoot up and you know that you have fentanyl in your dope, then you should have naloxone or Narcan on hand in case you do overdose. In terms of my protocol for dealing with fentanyl, it's cost effective. It keeps you in the outpatient atmosphere so that you can continue to work or interact with your family or go to school or do whatever is important to you. It is a comfortable detox because I ease you into the detox, and once we are into the detox mode, I introduce buprenorphine at a low enough dose and at the right time such that you can take that and it will gradually displace the slow release fentanyl from your system, so that you can then be placed on buprenorphine as a maintenance drug. I want to mention to viewers of this YouTube video that, you know, the idea that you're just going to quit opioids cold turkey and that you're going to get in a 12-step program and your life's going to be great, you're deluding yourself. That's not going to happen, okay? 85 to 95% of addicts relapse, often within a few days of attempting to stop. The 12-step recovery is something that I strongly advocate for opioid addicts, but first of all, we have to bring the cycle of craving, withdrawal, relapse, craving, withdrawal, relapse under control. And the way that you do that is with methadone or buprenorphine. Why is this so important? Well, it's important because death statistics are important. If you are a soldier in Vietnam, your annual death rate is 3% per year. Smoke a pack a day for 20 years, 1% per year. Alcoholic, 0.5% per year. Shoot dope, 7.2% per year. You are 2.5 times more likely to die from shooting fentanyl or heroin than you are from going to war, okay? So when I start you on methadone or buprenorphine, that drops your mortality rate from 7.2% down to 1.4% per year. Substitutive therapy with buprenorphine or methadone does what it's intended to do. It eliminates drug craving, it eliminates dope sickness, and if you do dope, you don't get high because your receptors are blocked. But it doesn't do anything about the emotional, spiritual, mental, physical reasons that you became addicted to dope to begin with. For that, you really do need 12-step recovery. However, 12-step recovery is not a good primary treatment for opioid dependence. You must stop the cycle of craving, relapse, withdrawal, craving, relapse, withdrawal, which occurs in the setting of opioid dependence. The only reliable way to do that is with Suboxone or methadone. If you've been using opioids for greater than a year, in 95% of cases, you change the underlying wiring of your brain, and your brain is always going to need to see some stimulation of those opioid receptors. Otherwise, you are going to develop something that in the literature is referred to as abstinence syndrome, but I refer to it as opioid deficiency dysphoria. And opioid deficiency dysphoria is similar to depression, but it's different. In depression, in advanced depression, the patient is sad, weepy, tearful, has feelings of hopelessness, helplessness, worthlessness, and these can progress to suicidal ideation and even death. But in the setting of opioid deficiency dysphoria, the patient is not overtly suicidal, but they wouldn't mind if they died because their life is meaningless, joyless, and purposeless without some stimulation of those opioid receptors. That is why methadone and buprenorphine are so important. And methadone and buprenorphine are very long-acting, whereas heroin or fentanyl are very short-acting. The short-acting opioids, they take you up quickly, that's the euphoria, and then they bring you down quickly, and that's the withdrawal. And, you know, when you're really strongly addicted, you're shooting up 4 times a day. In some people, 6 times a day. So they're going up and down and up and down and up and down. And that's what causes people who are doing opioids to spiral down so quickly, because, you know, they're in and out of various levels of consciousness, and you know, they are spending all their time chasing dope. It is an exhausting lifestyle. But methadone and buprenorphine, they bring you up to a level and then they just hold you there. And they eliminate drug craving, they eliminate dope sickness. And if you spend money on dope and then you shoot it, you won't get high if you're on the right dose of buprenorphine or methadone. So you just wasted your money. In any event, whether you choose inpatient treatment or a methadone clinic, or you choose to come to my practice for outpatient detoxification from fentanyl, I wish you the best and good health and good luck. This is Dr. Masters with Austin Addiction Medicine Associates. You can find me on the web at www.drugfreeaustin.com, or you can call me at 512-810-2079. Thank you.